Really great to see so many people that have joined us today. Terrific numbers.
Yeah.
Okay, shall I make a start? Well, as I just said a moment ago, welcome to this lunchtime webinar today. My name is Matt Greensmith. I'm a consultant in public health at Hull City Council. And today's webinar is around supporting smoke-free pregnancies. The webinar has been organised by the Humber and North Yorkshire Centre for Excellence in Tobacco Control, and we continue to benefit from their excellent work in helping us as a system address tobacco use right across and helping us organise our efforts right across the population. The webinar today is designed to provide the most up-to-date information and guidance to professionals involved in maternity care, family services and tobacco control. And we hope that we can equip you with the latest evidence, advice and strategies to support pregnant smokers in quitting, thereby improving health outcomes and those of their babies. We're really fortunate today to have Hilary Wareing from iPiP Health as our presenter. Hilary and her team bring a wealth of knowledge and experience in public health, maternity care and tobacco control. And they're dedicated to helping health professionals effectively engage with pregnant smokers and increase quit rates. Throughout the session, we'll address several key topics: how to increase quit rates amongst pregnant smokers and improve engagement strategies, best practice for utilising the National Incentive Scheme. I'm really keen to hear more about that, and current advice on vaping during pregnancy. So I'd like everyone to remember that this is an interactive webinar and we'll all get more from it if people ask questions. And if possible, if people could put their questions in the chat, Katie will be keeping an eye on those, and we'll have an opportunity at the end for a discussion. So I think, Hilary, would you prefer questions at the end if that's possible? Is that correct?
Yeah, I think that will most likely work best.
Okay.
Yeah.
Great.
And I'm going to leave plenty of time. This is a whistle-stop tour and then a conversation.
Okay, so for those who can't stay for the entire session, I understand that this session is being recorded and it will be circulated afterwards. Supporting smoke-free pregnancies is a critical component of the NHS long-term plan. Smoking during pregnancy is a significant risk factor, as we all know, for poor birth outcomes, including stillbirth and neonatal deaths. And providing real-time support in maternity units, we can help every woman who smokes to quit and ensure healthier futures for their children. Supporting smoke-free pregnancies is crucial for public health, and to make significant progress, we need a joined-up discussion on how best to support pregnant women before, during and after pregnancy. And this holistic approach ensures continuous support and maximises the chances that people will continue to remain tobacco-free. So, and just as a final thought from me, in Hull, we've made great strides over the last 10 to 15 years in reducing the number of women that smoke at the time of delivery. But even now, we're still around 5% higher than the national average was 15 years ago. And that shows from a Hull perspective, and it's not just a Hull issue, we have other places in the Humber and North Yorkshire patch that have really high rates compared to the national average, and we have places in our patch with sort of lower rates, which is great, than the national average. But in all those places, we want to see no women smoking at the time of delivery. It's such an important issue for us all. So thanks again for joining us for the webinar today, and I'll now hand over to Hilary. So Hilary, the floor is yours, and then we'll come together for the discussion at the end. Thank you.
Thanks, Matt. I'm just going to share screen, hopefully. I always like it when the technology works. Can somebody just tell me if they can see that okay?
Yeah, we can see that, Hilary.
Yeah. Great. I recognise some names in the audience and some I don't. And I know that there'll be people in this audience who know an awful lot in this area and have been working in it for a long time. And there'll be others that are newer to this area of work. But hopefully all of you will have some benefit from what I'm going to talk about. I'm going to give you a whistle-stop tour through what we should be doing, where we should be now, how impactful we should be. And really, what I'd like you to do is, as I go through the slides, think, are we doing that? Are we on that? Is there anything else we could do to actually better engage women or better support women? And we'll also talk about some new exciting things that are coming up to support you as well. So we're going to talk about the evidence, what the evidence looks like in practice, the potential impact if we do that really well. What about vapes? I know that's on the tip of everybody's tongue, so there's always a question. And I've got something new there. I've got the draft guidance that's going to come out from Ash and the Challenge Group, and I've got their permission to share some of the kind of headlines from that and talk a little bit about getting ready for incentives, because we all know that a national scheme is coming soon and we need to be ready to make the most of it. So just to start off and say, this is like a jigsaw to me. And if there's a missing piece, it really doesn't work. It's not about can we do this or can we do that? We should be doing all the practice that reflects the evidence. And we should remember that it's not just what we're doing when we're working with individual women who are pregnant and smoking or trying to quit, but to think about all the things that are going on around that we're not going to get a chance to talk to today, but are really important. The national work that's going on around regulation and legislation, the academics and the work they're doing, feeding us the evidence. The smoke-free hospitals, really important, the context in which we're talking to women about smoking. The local authority work, trading standards, environmental health, all of that matters because it's the context in which we are talking to women and supporting them. And it's important that you know about that other work that's going on in the context that you're working in. So let's start at the beginning of the journey, identifying and referring pregnant women who smoke. Got to be CO testing all women, booking at 36 weeks at least. And if they are identified as smokers or recent ex-smokers, then we should be testing them at every appointment. Not just to see if they're still on track, but to be able to give those motivational messages, the well dones, or to help them re-engage or engage with support if they're struggling. Raise your concern. I worry about some of the VBA conversations. This isn't just about saying you're a smoker and I have to refer you. This is particularly as a midwife saying, I am really concerned for you and your baby, and I need to refer you now so you can get the treatment you need. It's a really serious issue. This is a saving babies' lives intervention, and we have to reflect that to the women. And women say they want to hear that concern because it's a hard ask. And if we are that concerned, we need to be doing rapid referrals to stop smoking service. The longer you leave it, women tell us, the less worried they are. And we need to do a sell. Women will tell us how often they've been let down, in their view, by services. I don't mean particularly midwifery, but generally, social care, healthcare. And so we need to sell that offer. We need to say about the amazing services we've got and how they will stay with her during pregnancy and beyond. Let her know that you're working together with the people who are going to support her, and that you will be having conversations and hearing about how she's doing, and that you will remember to ask her next time she comes, and you'll have another conversation. If you get that right, it makes a real difference to how they perceive that reach out from the TDAs or the Stop Smoking, local authority Stop Smoking service. And just remember the context in which you are actually raising that concern, and for the Stop Smoking services, the context in which you're reaching out to that woman. These are some of the other things that are going on for women during their pregnancy. The pregnancy, it might not even have been planned. And that in itself is a huge unexpected life event. Money is a big one at the minute when we're talking to women. Money is huge. How am I going to cope as having a baby? How are we going to be able to afford this? How am I going to be able to pay my bills? So things like poor housing, food poverty, illness come into it, fear of crime, fear of domestic violence and other violence, worries about other children, being anxious about their pregnancy, mental health issues for themselves, other family members. And now we find more and more young families who are actually carers for other people in their family. All of this is going on, and we're going, and you've got to stop smoking. It's not that we shouldn't say that, but it's really important that they believe that we understand that the context in which we're asking them to do that can be quite complex. So for stop smoking services, for the TDAs, if you never get to speak to them, if they don't engage with you, you can't do the amazing work that you are capable of doing. It needs to be rapid. That again, the longer you leave it, the less worried women are. If it was really serious, they'd have rung me straight away. They'd have got in touch. And keep trying. It may take repeated efforts because other things are going on in their lives. Reflect midwife's concern. Listen to her situation. Reflect what you've heard and sell the offer. Say what you can do for them and listen to what they've told you and give them an appointment that makes it more possible for them to turn up. If they've got 3 young children, and they live 2 bus rides away from the hospital or from a distance, from a family hub, they're not going to come, or at least they're less likely to. If that woman has got really bad morning sickness, she's going to be less likely to come. Can we offer a home visit? Can we reflect what we've heard and say, this sounds like something that might work for you? Affirm that most women come to their appointments, but what do they want you to do if they can't attend? It gives you permission to reach back out. But the biggest thing is make it possible. Don't make it impossible. For the stop smoking services, it needs specialist stop smoking support. And I was just looking at that word specialist, and I most likely should have blown that up even bigger. Online training without any face-to-face is not sufficient to support women with a complex behaviour change in a complex time in their lives. We need TDAs to be given the opportunity to do their best work. That means that the online training is brilliant, but it needs face-to-face. You need to learn about motivational interviewing and have the chance to actually practice that. You need to be supported in your practice, so there should be mentoring, perhaps peer mentoring, and there should be support to develop that practice. And we should be looking at our outcomes to make sure that training and support is working. It should be part of routine care. It shouldn't be seen as something separate. This isn't about stop smoking. This is about saving babies' lives. This is about what we do as a maternity service to help get a healthy baby. Are you offering face-to-face, virtual or telephone? I understand for many women, there will be a mix. You have a firm belief that first visit should be appointment should be face-to-face. And then you should work out with that woman what's going to work for them, the right combination to get them a smoke-free pregnancy. But the support has to be intensive and ongoing through pregnancy and beyond, really to have a smoke-free pregnancy and to stop that relapse postpartum as well. And to know that that is happening and they are smoke-free, we need to be CO validating. And when we come on to incentives, you are going to need to be able to regularly CO validate that they are quit. So how are you doing that now? Are you doing it face-to-face? Or are you using ICOs as part of your kind of toolkit to allow some validation to be done when you're doing those virtual contacts? And for when incentives come in, and you will have to CO validate every single contact, have you got the equipment you need to be able to do that? And obviously the other thing you need is nicotine replacement, and I include in that vapes as well. So we need to make sure that we've got advisors experienced in knowing how best to prescribe NRT and how to use vapes during pregnancy. Oh, hang on, let's see if it'll go down. No, doesn't want to go to the next one. Let's try. Here we go. So, hang on, it's jumped. I will be back in a minute. Just there we go. That's it. Back. Sorry. What do women say they want to us? They want your expertise. They want you to be the expert. They want you to be motivating, responsive, realistic about their situation, compassionate, consistent, truthful. Sometimes I know it's hard to tell women just how dangerous smoking is, but what women say is we need to hear that. We need to hear what the truth is. We need that knowledge to make the decisions about what we're going to do. It's not for the professional to hold that knowledge. They have to give it to us in a way where we can utilize it to make our decisions. I think the consistency is a huge word as well. We ask women to make a big change. Can you ensure that you are there or somebody is there for every appointment that they're going to need with you to do that? My worry is sometimes that because of resource issues, we start them off well, maybe, and then you have somebody leave, somebody go on annual leave, and all of a sudden there's nobody to actually support that woman in her next appointment. We really need to reflect, have we got a model that allows consistency? Because one of the things I said earlier is about women telling us about all the times they've been let down by the system, and we don't want to be part of that system that lets them down, because it will be very hard for them to trust us in the future. And within all of that, it's going back to what I said about the complexity of women's lives. I was just looking back. We asked some TDAs to actually look at their next kind of couple of hundred appointments they had and divide up a pie chart into what they talked about in those meetings. And when we reviewed it, only 61% overall was actually about stopping smoking. The rest was around alcohol or drug use, problems with their children, problems with their pregnancy, finance problems, and listening and signposting to other specialists that might be able to help them. So it's really important that you know what is around you in the way of services that you may need to help women reach out to address other worries, which will also help them focus on being able to stop smoking. So have that in your toolkit, and it's really useful. I mentioned vapes. It's the hot topic, isn't it? We're doing quite a lot of work around youth vaping at the minute, both nationally and in local areas. And there's a lot in the press about that. And what we've got to do is separate that off from how we're using vapes to support people to quit. So this is the literally hot off the press ASH draft update on what we can say about vapes. This will be coming out shortly. It's literally just got off to the designers to be kind of made to look pretty and to be printed so we can get it out to you. Generally, and it's all referenced and it's all in the document. But 60% more effective than NRT. Nicotine, relatively harmless. We must remember that. Vapes may be more addictive than NRT, but less addictive than cigarettes and carry only a fraction of the risk. And it's really important that we don't conflate the risks of smoking and vaping. There's a misperception in the general population about the risk of vapes, and we need to make sure that we do not discourage women from using vapes when that could have been the way they had a smoke-free pregnancy. This is about vapes that are legal to buy in this country, and we all have concerns, and there's work going on about the illicit vapes. But you can check if the vapes that you're hearing about are on the MHR register. So that's the link below to know that they are legal. What does it say about use in pregnancy? It does not appear, vapes do not appear to be associated with any adverse effects in mothers or their babies, and are more effective than nicotine patches in helping women have a smoke-free pregnancy. And the vapor that can be found, there are toxins in there, but they're at much lower levels than tobacco smoke and at levels not associated with serious harm. The secondhand vape, significantly lower than proven harms from secondhand smoke, and no evidence that short-term exposure to secondhand e-cigarette vapor is harmful to health. So this is good news. It can help you feel more confident in your conversations. What are you going to tell women? It's the best thing that they can do to quit smoking. And if vaping helps them do that and stay smoke-free, it's far safer for herself and her baby. And they appear more effective than nicotine patches. And regular use of vapes or NLT is not associated with any adverse effects on her or on her baby. Oh, it's gone again. There we go. Okay, we're back. Quit smoking completely. This isn't about vaping and smoking. This is about quitting smoking completely and using vapes to ensure that you stay smoke-free. Short-term exposure to secondhand e-vapor, not harmful. And an important one, because I've been asked this quite a bit recently, no reason to believe that using a vape would compromise breastfeeding. So lots of good news, but watch for it coming out. I'm sure Scott and Katie will ensure that you get that briefing out as soon as it's available. And any questions about that, do stick them in the chat and we can have a talk about them. If you think you're doing all of those things well that we talked about, then hopefully you're going to be ready for what's coming next. If you think there's some things that maybe you could step up, you could improve, then there's a real opportunity to get those things right and ready at the moment, because we have a national incentive scheme coming soon. We haven't got the launch date, but it is very soon. And the aim of that is to offer financial incentives to pregnant women and in the early postpartum period. So it is about helping them stay quit, but not just during the pregnancy, postnatally. So do you offer any support to women postnatally at the moment? And you might want to think about how you can do that, because the national scheme that's coming out will have a postpartum element. That's to try and stop relapse, so that hopefully if women come to another pregnancy, they're going to come smoke-free, but also to help with reduction in secondhand smoke in homes as well. How does it work? It increases motivation to quit through a financial incentive. Most of the schemes at the moment that I know of are Love to Shop vouchers, and it's around about the £20-25 a week for the first 4 weeks, and then most likely around the same level for each month through the rest of pregnancy, with a payment postpartum at around 12 weeks if they stay smoke-free postpartum as well. It is a really strong incentive for women, and we know by the evidence, and by the evidence not just academically, but the evidence in practice from places like Greater Manchester, that it enhances significantly the number of women who stay quit compared to services who do not have those incentives. It keeps women more engaged. And, at the moment, it's really interesting. We did some insights a while ago, and I just said 4 or 5 years ago, women told us they spent those incentives on maybe saving them up and buying something really special for the baby. It might have been about the pram they wanted or some equipment for the home they wanted. Now we hear more that those incentives are being used on a weekly basis to feed the family. It's about easing the everyday pressures. And if we can do that, that really helps women focus better on the things they need to do to have a healthy outcome, like stopping smoking. So watch. I don't think it will be long before you see the news about this. And you really want to be ready to have as many women as possible coming through your service that you're going to be able to offer these incentives to that are not coming out your local budgets. That this is coming from DH. So it's a real opportunity to put an extra offer in for those families. So what do you need to be able to deliver that level of service? Well, I've got some questions about resources, and I mentioned it earlier. Have you got enough whole-time equivalent to offer the level of support required? How have you calculated that? So however many staff you've got, how did you come to that number? Was it based on available finance, or did you use a calculation based on how much time you were going to need for the number of women who were coming to smoking and pregnancy in your area? What happens when somebody's on annual leave or leaves the service or has sickness? Are you able to adapt your model to ensure consistency of support throughout pregnancy and beyond? I know that Franklin and I've done work and on trying to calculate the whole time equivalent, and we would say to support a woman through a pregnancy, most likely need somewhere between 6 and 8 hours, but not every woman will come to you early, and not all women will go through the whole journey. So I asked Fran the other day, how many are they calculating at the moment? And for one whole time equivalent, that equals about 225 women who are smoking at time of booking. Not in your service, but smoking at time of booking, because it still takes time for the ones that don't engage or take time to engage. So you may want to reflect on that and just go back to your services and think, are we there? Matt mentioned about the challenges and how hard they work, and while the rates are going down, it's taking time. It's worth looking at somewhere like Greater Manchester. You'll see that they started, when we started to implement smoke-free work in GM, they started well above where the national average is. And they are now just tipping onto the national average. The little strange bit in the middle that's red, that's when there was disqualification of data due to a new information system that was going in. But you can see where they are now, not just in reduction, but that inequality with the rest of the country. And what they've done is what you've just seen me explain. So it works, and we can all do it. How are you going to know for each one? So again, Fran and I worked on key performance indicators. So you to know if it's working locally, you can take this one slide, look at your data, and then maybe focus in on the areas where you're not reaching the levels that we know you can reach if you implement that evidence base. So 95% smoking at time of booking are tested. There's always a reason not to, and it's most likely because something's happened at that booking visit that's impacting the viability of that pregnancy. And greater than 95% referred. How are you referring them? Is it paper still? How quick are you getting them there? Or have you got an automated system? I know a lot of people on Badger now have automated. Are you managing that within one working day? Because that quickness really matters. For every day you delay, the number of women who will engage will decrease. How quickly are you reaching out from the stop smoking services, or how quickly the TDA's reaching out? And again, how quickly are you managing to get them an appointment with you? Where there's two stats, we know that the 60% is, for instance, is where you should be. That's on the referrals leading to a completed appointment. 60% is absolutely achievable, but we've got services that are managing 75, so it's possible. So How many are getting completed appointments? Referrals leading to a quit being started. How many are setting a quit date? How many are quit at 4 weeks? How many at 70? How many at 12 weeks? Take those, look at your data, I would say, and then look at where your challenges are and think what you might be able to do to actually improve that performance and ensure that you get more, enable women to be more likely to be smoke free at the end of their pregnancy. And I know Yorkshire and Humber have a great network, so maybe work with your colleagues in other areas, do some comparisons. We're doing better in one area, but they're doing better in another. Have a conversation, work out why they're doing better than you in one area. And, plagiarism is a sin, isn't it, in academia, but plagiarism is a necessity in public health. Take what they've been doing, see if it'll work for you. And if you've got something that's working better than in other areas, share what you've got. That's the way that we're going to get there quicker. Any questions? And I think I've just about, in fact, I've done it in half an hour. I'm impressed with myself. I'll stop sharing. Matt, that's quite good for me, I have to say.
Thank you, Hilary. Very disciplined. It's really clear that you've got a lot more to say on this topic. But yeah, thank you so much for that run through. I'm sure we will have some questions coming up, and I can see some in the chat. And if I might use Chair's prerogative, just a couple of observations from me before we move into that. I think what came across really strongly for me here, there's sort of two different domains that I was sort of thinking in, that you made me thinking when you were talking. One is that you really made me think about empathy and the way that services recognise that the challenges that women in pregnancy have that smoke. Thinking about people as individuals and the challenges in their lives and the support that they need. Pregnancy in itself is challenging enough without trying to give up a highly addictive substance at the same time. So that came across really strongly from me. And then the other thing that came really across really strongly was your encouragement to focus on every detail, and those KPIs at the end sort of show where you can lose the opportunity to influence women at different stages of the pathway. Yeah. And those KPIs were a really, really good reminder of all the sort of, there's a process to this, and if you focus on different elements of the process, you can stop yourself. You can, thinking at a population level, you keep more people within the program than you would lose. It's a bit of a leaky pipeline, isn't it? And if you don't pay attention to each element of the process, you can lose the opportunity to keep women motivated and engaged with the service. Yeah, really great. Thank you, Hilary.
Yeah. I think that's Matt. I think that's really important, because people will tell me when I go in, sometimes they've got they've got this amazing quit rate of 70-80%, and I'm thinking, wow. And then I see that actually they're only seeing 20% of their women who are smoking at the time of booking, and I'm saying you need to be getting that 70%. With 70% of the women who are smoking at the time of booking. So sometimes if you're not looking at the wrong figures, you can feel kind of secure in what you're doing, and not realize that actually you're missing a whole load of potential. And on the empathy, I think it's huge, and women tell us it's huge. They tell us that people say, oh, your appointment's next Tuesday afternoon at wherever, without listening. And then we have all that work trying then to re-engage them, whereas a little bit more time spent in that first engagement and response can make a massive difference in your time and your likely engagement.
Thank you, Hilary. Really interesting reflections. I'll hand over to Scott and Katie now, because I know that they've been keeping an eye on the questions. So I'll let Katie and Scott organise us in terms of how we want to bring those into the discussion now. Yeah, thank you.
Thanks, Matt. Well, there was I'd been emailed a couple of questions. Glyn's answered one, but I'll send it back to you anyway. The ICOs. What are ICOs? And on the back of that, I don't know whether this is for Dave or Becky or Vicky, is that do we actually use these within our trusts? So perhaps Hilary, if you can just explain what ICOs are, and then I'll hand over to see whether we are using them.
Sorry, we're terrible for acronyms, aren't we? It's individual CO monitors. So they're small devices that offer single use for one person's use. And so you can give them to women to take home, and then they can do their own CO level. And the ICOs are linked to an app so that you can actually record it and share it with your advisor.
And to your second
Dave and
part
Becky,
of the question,
do we use those?
Yeah, we don't use them currently, Scott. I mean, they have had quite a lot of use, I think, in local authorities. They were picked up for quite a bit for pregnancy and were very useful. They're useful when people can't make them in. We're in a different funding envelope in the long-term plan, and while they're not massively expensive in comparison to the cost of the benefit of use of them for pregnancy, they're probably not within our current budgets unless things look slightly different in terms of NHS world than they do at the moment, which is quite a stretched place, as we all are.
Yeah, I think it will be safe to tell you at this stage that I kind of know that there will be a small amount of funding within the incentive scheme to provide ICOs. But I think Yorkshire and Humber will have some access, but don't get excited about exactly how many, because the budget won't meet everybody's needs.
Are they still around £45 a pop when you bulk buy them for a lot, or is they?
No,
let's not get into that now,
Okay.
Dave.
They've gone up.
Becky, did you want to come in there?
I was going to say something similar. I know we've had some tests done in various areas, and there are still some being used across the patch. I think North Yorkshire had a trial of them just because of the rurality of their area and the difficulty of getting people in for face-to-face contacts and monitoring. And I see somebody's put in the chat that they do use some. But you're right, they are expensive, and I think, if there is an opportunity to get some in, we'd happily do that, but I think we need to prioritise where and which populations that they best are used in for maximum effect.
Yeah, well, we'll need to have a think about that, and Jenny's come in there to say that they're actually single use, so your point really is kind of horses for courses. When do we use them? But I think that the point coming in was that we're going to have to think seriously about CO monitoring with the incentive scheme, because that's how we'll be monitored. Okay, the other question, Hilary, I don't know whether you can add more to this, was when is the national incentive scheme coming? We've been waiting a bit for it.
The risk of being proved wrong, I think it's imminent.
Okay, we'll leave it at that, because we can't really say much more, but we're hoping that.
I think we've lost Scott there, haven't we?
Yeah.
Oh, back again.
Oh.
Yeah. We did have another question from Josh asking if there's a recommended accredited training programme for all stop smoking advisors across our ICB to deal with more complex maternity cases, so we all have the same level of knowledge and expertise, which I think is a really great point. I know Becky had put in that the LMNS have a recommended package for all staff, specifically around smoking in pregnancy, but I don't know whether that's something we can look at across as a system, Scott, just to see what's out there, what we can pull together.
Yes, there are things that we've got in the pipeline around training and development, and smoking pregnancy will come into that. It's something that we may well be working with colleagues across Yorkshire and the Humber on that one. So we'll keep you posted, but it's certainly something that we need to look at. Hilary obviously identified the need for specialist face-to-face training, and I think that's the case for all stop smoking advisors. to be honest. So it's something that we're going to look at smoking in pregnancy at, but also, from my perspective, we'd want the best and most knowledgeable stop smoking advisors in the world in our patch. So that's what we're going to look at doing.
Great. Becky, go for it.
I was just going to add in, I've put the link in the Q&A session to our training package that we have available. It's been put together by Vicky, our Stop Smoking lead, and the TDAs across the patch. It's not going to answer every question, but it's a really good starting point. And we're absolutely not precious about it at all. So anything you want to beg, borrow or steal from it, use it in its entirety or just take some chunks out, we're absolutely fine with that.
Brilliant, thank you. We did have another question asking, are vapes only available from the councils? Dave, I don't know whether you can shed any more light on whether we're able to get them available from the trust. As far as I know, that would be an absolute headache, but I'll let Dave
so
come in.
Some trusts have got vape vouchers available, so they've used some of their NHS, some of the long-term plan money allocated for nicotine replacement therapies and support to provide a voucher for people to take to the local vape shop. So they've got a local vape shop who are in cahoots with, who have NTSCT trained advisors, where they take the voucher along. The person has a conversation with them about it being a quit attempt, shows them the opportunity, the vapes that they've got. The person chooses one and then can use a vape through the duration of their care. With the
we'll have a direct supply for inpatients though.
No, because I mean it's possible. We're looking across mental health and potentially linking up with the council and accessing the vapes that are available through the Swap to Stop scheme, which is the 1 million vapes available. So those are the ones that are available purely through the council. But there's nothing to stop a trust setting up a independent relationship with a local provider who has NCSCT trained staff in their shop to issue vouchers to people who would then go and take a vape as part of their quit attempt.
And Dave, we should remember that the trusts and the local authorities who are supplying vapes know that it's actually cheaper than NRT. So I know there's quite often a worry about cost, but in fact it's the reverse.
And I think the good thing about providing a voucher to somebody is it's upon them to enact that voucher. The money doesn't spend until they enter treatment. If you give someone an RT to take away, it can, sit somewhere and be unused as well. So there's a value in making, everybody who gets a vape uses it. And there's nothing, as Hilary said, we do this in maternity services in some of our trusts as well as for acute patients.
And I think can I just say one of the things I didn't mention was the people surrounding that woman and what you offer to them. And we do a lot of work with dads, not just for smoking, but more broadly around dads. And we should be thinking what can be given to them or other people at home. And we are certainly moving towards using the Stop to Swap as a real opportunity to have an offer to that wider group. Matt, an interesting one, I think, for Hull, and I don't know if anybody else is doing it, but we're doing work more widely on CO in pregnancy, the environmental CO, and we use fire and rescue in some of our areas to do safe and well visits for families. And we're certainly having some good discussions with FRS at the moment about potentially being one of the mechanisms to get Swap to Stop vapes out to homes of pregnant women. So I know you've got a really good FRS service there. It's just a thought.
Yeah, I think there's lots of ways that we need to engage. There's not just one. Got a question from Yvonne saying, how do we get vouchers for vapes? So we do have a little bit of work to do in terms of pulling colleagues together, because this is where I think local authority colleagues and trust colleagues need to work together to get those pathways right, because I think all of our local authorities now provide vape vapes and vape starter kits. And I think from a point that Hilary made around initial outlay and cost, the cost of living being a real issue at the moment, is that actually the initial outlay for vapes can be beyond someone. So essentially it's easier to continue to smoke than to have that initial outlay. So I do think that we need to get better at providing pregnant women a way out of tobacco, and I think we need to work together better on that one. There was a question around training. Someone had put in that there is NCSCT training. So we're not taking, Hilary, just back me up on here, we're not taking away from NCSCT training.
No,
absolutely as a
100%
core. But what we're saying is that it's all very well having online training, but I think when you come into very specialist areas, we need specialist training on top of that core.
Absolutely, it's not instead of, it's as well as.
We did have another question asking whether the benefits to the woman themselves and their health are highlighted, as well as the benefits to the pregnancy and the baby, and does that help engagement?
That's a really interesting question. I'd always say, yeah, it has to be around the woman and the baby. But if you ask women, it's about that pregnancy. That's their focus. At that time, they haven't come to you thinking, I want to quit for my own health. The whole focus is around that healthy baby. And you could say that's about them. That's hugely about them. So while I think you should say the benefits for them as well in the longer term, not least being around and being healthy for their children as they grow, for them, what they hear is more about having a healthy baby.
Great, thank you.
Couple of questions from me, well, not from me, that have come in. One from Josh, who asked about NICE guidance and vapes, because sometimes this is a barrier in terms of getting them out. What would you, do we know anything about NICE, and what would you say to kind of counter that?
Oh, it's how you read NICE guidance, I suppose, isn't it? Because the evidence shows that it's really difficult for women to quit without some medication or vapes in that mix, that behavioural support is unlikely to, or very much less likely to be successful. And therefore, I think it should be in the mix of what we offer. And I think that fits with NICE guidance. I don't think the way we suggest doing it kind of has got any tension with NICE guidance. It's how you read it. But not everybody will read it the same.
Yeah, I mean, it is tricky for certain individuals working in certain organisations. Some organisations seem to be more risk averse than others. What I would say is the evidence is quite clear that vapes are the most effective quit aid out there, followed by Veronica, which we can't use with pregnant women anyway. Cytosine can't, and in terms of combination NRT is a bit lower down. So I think it's a balance between what we know is actually getting women away from tobacco, which we know is deadly for both mum and baby and family if they're smoking inside, and to get them off tobacco.
Yeah. And I also think a lot of women listening to the service now, a lot of women are actually asking about the vapes. So the want to use them is coming from them. Yeah. And you add to that conversation, but with your knowledge. But a lot of women are coming saying, can I use a vape? And you're therefore responding to that woman's need to have some form of medication or NRT or nicotine from another source. So quite often I think it's responsive rather than you actually suggesting it without a woman trying without.
Okay, Dave, you've got a question, and then I've got one final question before Matt will need to wrap up.
It was just a follow up for the point Hilary made. So I think all of our trusts have taken the decision that they will support partners as part of the long-term plan. So
Perfect.
it's provided care alongside the pregnant women. Their care records are linked. We don't obviously report them back through long-term plan to NHS England, but everything that's available to the pregnant woman is available to the partner as well for the duration of the pregnancy and beyond.
Yeah, I think that's hugely beneficial. Just to say as well, not out yet, but Kenvu, I've just reviewed them, have just done a series of videos with some alongside it some advice. They've been working with dads, so the videos are from dads who quit. So they'll be out soon, which are really nice actually.
Great. One last question then before we pass back to Matt, which was there were a couple of people who were quite startled about some of the insights that you talked about with pregnant women, and that pregnant women just, want a very professional but very kind of matter-of-fact way of presenting the facts that obviously you can do in a compassionate, professional way, but need those facts presented to them so they can decide for themselves. I just wanted, if you just wanted to sort of follow up on some of those insights on that point.
Yeah, I mean, some work we did was around women who hadn't quit and having conversations about what we knew about it, and that was the group that we got a lot of these insights from. And it's about where the power sits, and the power should sit with the woman. We should be empowering them to make choices about their health. And if we keep that data and that information to ourselves, it's us that are in control, not them. But it's how you present that. I think, if I'm providing support, I say, I know things about what tobacco does during a pregnancy, and what I want to do is to tell you what I know, so that we can have a discussion about what you then want to do. So it's handing them the power to do it, but it's how you describe that. And it has got to be with compassion, and it's got to be without blame. And when you do that, that is a much better conversation with that woman, because you're empowering her. You're not using your power as a professional. But they do want the truth, and they expect the truth, and they're really annoyed when they don't get the truth and they find out later.
Any midwives want to come back at all in terms of that? It'd be interesting to hear that. Anyway, back to you, Matt, I think, to wrap up.
Thanks, Scott. So I'll conclude by sort of just reflecting back what I think I've heard. Firstly, I've learned an awful lot. I haven't had an opportunity to work to date on smoking pregnancy in my career. So this has been a brilliant CPD session for me this lunchtime. So thank you, Hilary, for that. The first thing is that this isn't, although we've heard about forthcoming guidance around vaping in pregnancy and imminent further details on financial incentive schemes, we've also had some reminders about how we can make our smoking cessation pathways in pregnancy more effective. And those things are not about new developments. They're about good practice and the quality of the conversation that you have with pregnant women. So yeah, a really, really great reminder about effective smoking cessation in pregnancy, as well as really helpful updates on forthcoming vaping and details on the financial incentive schemes. The recording will be distributed after the event, so no need to sort of send an email asking for a copy. It's going to come out. Will the slides come out too? Yeah, okay. So the slides will follow as well. So it just remains for me to thank everybody that's dialed in today. It's been a really great session and a really good use of an hour of people's time over lunch. So thank you for giving your time and dialing in. Thanks very much to colleagues at the Tobacco Centre of Excellence for organising today. Again, thank you, Kate, Dave and Scott, and Becky, thanks for your support today, and Hilary for your time and expertise. Thank you very much for sharing that with us today. So enjoy the weather, enjoy the rest of your days, and I'll see some of you soon. Thank you. Bye now.